You recording on the laptop? Okay. All right. I'm gonna give you 3, 2, 1.
Hello, everyone. Welcome to Dean's Chat, where we discuss all things podiatric medicine. My name is Dr. Jeffrey Jensen. I'm the Dean at the Arizona College of Podiatric Medicine and the host for the Dean's Chat podcast. Once again, I am joined by my co-host, Dr. Jensen and Richey. Hi, Joe.
Hey, Jeff. How you doing?
I am doing great. I'm super excited about today's episode. It's been a long time in the making.
Yes, we have some excellent guests. Fun discussions for sure.
Absolutely. Well, let me do kind of an informal little introduction, and then I'll give you a little more formal one afterwards. I'd like to welcome the founder and CEO of Upperline Health, Mr. David Thorpe. Welcome to Dean's Chat, David.
Hey, Dr. Jensen and Dr. Richey. Thank you guys for having me and excited to be here.
Very excited. And also a repeat guest. Welcome, Dr. Jean Pascarella. Welcome back to Dean's Chat.
Hey, Dr. Jensen. Hey, Joe. Happy to be back.
You know, we're fairly informal here on Dean's Chat. David, if you don't mind, let's go. First names, David, Joe, Jean, and Jeff.
Love it. Will do. I will do my best. Sometimes I still revert back.
No worries. It's all good. Let me give you a little more formal introduction. David Thorpe is the founder and chief executive officer of Upperline Health, the nation's largest physician practice dedicated to specialty value-based care. From its initial clinic in Hoover, Alabama, David has led the growth of Upperline Health to treat over 500,000 patients annually through 300 doctors in 7 specialties across 150 locations in 19 states. David, you've grown since you and I talked.
That is true.
Upperline's mission is to transform specialty healthcare towards comprehensive care that breaks down silos and provides whole person treatment over triage whenever a patient is seen. Patients are engaged via their specialists and then served by an interdisciplinary team that provides 24/7 care in the clinic, home, telehealth, and hospital setting. Prior to Upperline, David was at Aspire Health. He worked in the government, and he holds a history degree from Princeton University. Welcome again, David.
Thank you so much. Glad to be here.
And then just a little refreshing on Dr. Pascarella here. Jean has served on the Podiatry Foundation board, and he is the executive director since September of 2024. Dr. Pascarella serves as the regional medical director for Upperline Health. We're looking forward to hearing more about that role. You are also faculty at the Advent Health Hospital System residency program, teaching podiatric residents in what is recognized as one of the top residency programs in the country. Welcome back to Dean's Chat, Jean.
Thank you so much, Jeff. Thank you.
All right, I'm going to kind of kick it off here a little bit. I've got a question right off the top for you, David.
All right.
Why is podiatry at the center of Upperline, or kind of in the center of its evolution from the beginning?
Yeah. So I'll take you back maybe just to help contextualize it. So my previous life was a company that was end of life, really sick, complex patients. So think sort of the last 24-ish months of life. And we would see a lot of recurring themes, as you might imagine, and I'm not clinical. You can't mistakenly call me doctor. But I would sit on these clinical calls and you would see certain clinical themes. And one of the ones that even for end of life sort of stuck with the non-clinician in the room was these end of life wound care patients, these LEA patients who had been going through, multiple amputations oftentimes, which again, sort of the stories ended up just sticking out for me when I would sit on these calls with health plans. We would largely do these rounding calls with different health plans, our doctors and their doctors. And even though all of our patients were end of life, these were like the saddest of the sad that kept coming up. And it kept happening in every market, doesn't matter what market, doesn't matter what health plan, we just saw it across the country and they kept asking for help. And by the time they got to us, it was really just way too late. We weren't, able to do a whole lot. A lot of times they were already sort of on their way to hospice by the time we saw them. But I saw it often enough and frequent enough that, I said, hey, this clearly isn't working. It's broken within our healthcare system. These patients are getting really, really tragic sort of end of life care and tragic things that are happening to them. As you start to look into it, I know everyone on this call and in the podcast is well aware of it, but most of the healthcare system is not aware of it, right? It's something that's like almost, I would describe as third world country-esque. What's happening with diabetic amputation and foot ulcers and, and sort of that progression. which if you don't live in that, you kind of don't hear about it, right? It's sort of oftentimes lower socioeconomic, very rural, and I think just a national tragedy that it's not something that we talk enough about at a national level, outside of really our specialty. And so so I saw that again firsthand at the tail end where it was kind of the worst outcome, and said, you know, we can do better. How do we do better? Let's go upstream of where these patients are so that we can try to avoid that. And that then led me to podiatry, who I don't know that I actually had gone to podiatrist actually before, but I really just looked at the data and I said, like, who's seeing these patients, and where are they being engaged the most? And so the data was pretty clear. If you look at where they are and who sees them the highest concentration and the highest frequency, it's podiatry. And so that began the journey in 2017 to one doc shop in Birmingham, Alabama, that a friend of mine recommended, who was a medical sales rep. So that's how I ended up with that first practice.
2017 seems like yesterday, but it's still 8 years ago. And
Wow.
so if I'm hearing you right, what you're saying is that podiatric medicine allows for stratification of a patient population such that the highest risk patients are being seen by podiatrists.
Yeah, no, that's right. I mean, yeah, if you think about sort of their model, an Oak Street model, or some of the primary care, for them to impact the spin curve, you know, they've got to be good at oncology, ESRD, CHF, COPD, diabetes management, all, you know, probably 10 different things, because they can whittle away, you know, better outcomes at small margins in each of those. But for a specialist, because 60% of our value-based care patients at least have diabetes, or 60 to 70% have PVD, we can be really good at those two things, right? And it impacts almost all of the patients, right? And so you're able to really move the needle on the cost side and in the outcome side by specializing, right? In some ways. And so you know, it's kind of in how I say it's in the name. Specialists get to specialize, and what we mean by that is we get to specialize in the types of patients, right? You get a more narrow band, and as you said, kind of a different stratification. Because if you think about a lot of these value-based care programs, you've got primary care, and then you've got like what I did in my previous life, which was really sick end of life. And there's not a lot in between. There's really not a lot of groups that are saying, hey, if you're, you know, maybe complex with a couple of chronic conditions, you're sicker than your average primary care, but you're not train wreck end of life type patient. And a lot of those patients aren't getting these types of sort of wraparound services and comprehensive interventions. And so it's been cool to see how we've been able to kind of fill a need there.
Brilliant. Gene, I wanted to bring you into the discussion. You're a regional medical director. What does that look like for you? And what is your role, and what's your day-to-day duties, if you will, if you don't mind jumping on in here?
Sure. This sort of has evolved over the years. David said 2017. I met David in 2018. So early 2018. And I don't know how the introduction was made, but we came together, and I've been in practice probably 30 years at that point, and here he walks in, probably 30 years old. But, you know, we really had good conversation. I loved his vision, and I really believed in him and his integrity and his character. So over the years, my role has evolved. And as we sit here today, it is the regional medical director for Georgia and Tennessee. So I sort of sit between the management side and the clinical side. So I'm responsible for clinical oversight of our providers, risk coding on the ACC, on the HCC coding for the ACO, serve on various committees, mentoring some of our younger doctors. We have in Georgia, especially, a number of younger doctors and de novo offices. So responsible for bringing them along as well.
Bill, and you and I have experienced over the last couple of years, a lot of our students that graduated from residency have been joining up with you at Upperline, and that's fabulous. Joe, your thoughts on the discussion?
Yeah, I love hearing the origin story. It was so interesting, being a non-clinical person and seeing where the needs are and how do we bridge the gap in the care. I'm curious, David, as you've been able to witness, because I'm sure podiatry isn't the only, Upperline Health is a specialist group. I'm curious what your thoughts are in terms of where we're going in the future of medicine. We've obviously seen over the last 10, but definitely over even the last 15 years, kind of consolidating and changing of the medical atmosphere. I'm curious what your thoughts are about where we're going.
Yeah. Lots of thoughts. I'll hit some of the highlights. I think healthcare is going to continue to get complex, and I think because of the complexity, people are always going to band together. I think as that continues, I mean that trend is unfortunately not going anywhere. I think whether that's government driven or health plan driven, or honestly a combo of both. It's a highly regulated industry. So I think that will continue. I think, as you think about what we do specifically to value-based care, CMS has set a really very public goal that they have reiterated a number of times, which is to have 100% of Medicare fee-for-service in value-based care arrangements by 2030. Depending on how you cut the data, they're either half the way there or 30% of the way there. They got a long way to go. But it's already having impacts in some markets more than others. California, or where you guys are in Arizona or Florida, is a lot more mature than Kentucky or some other markets that we're in. But some folks have been feeling this for a while. I personally believe for whether it's specialists or I just say doctors that live in sort of the E&M world, and so you can think that's obviously us. That's a cardiologist, a GP cardiologist, or any sort of specialist that's treating a lot of chronic conditions that live in the E&M world, that have historically not been the ones that have gotten advocated for in the pay increases, right? A lot of that's gone to much more specialized surgical groups. I do believe the money will continue to shift, meaning that the incentives and the payments in these types of models are towards preventive care, right? That's the whole concept of this. And so, I hope that that the pie continues to sort of shift that way. I think we're seeing that within our group, within our doctors, which we can talk about. So I do believe that will continue. I hope that leads to a lot more folks coming into the specialty, which we might want to talk about as well. Because you see the payments going up associated with that. And then lastly, I'd say. One of the things that we talk a lot about, and I'm passionate about, is we're huge proponents and fans of the PCP model that is high touch. It's I think objectively better outcomes when that happens. I also think we need to be realist about the supply-demand imbalance and how a lot of customers, and we say customer a lot, use our healthcare system. So there's depending on what study you look at, probably 100 million patients who cannot get a PCP right now. I think the utilization of a true PCP who is trusted has gone down by like 11 or 12% in the last 5 years. It continues to go down. And if you think about it, like we're empowering patients to be more consumers, just like they are on Amazon, and to pick up and move. And I think that is leading to patients being much more itinerant and the doctors they're going to. And so I think we also want to acknowledge, or one of the things that we try to do at Upperline is acknowledge that we love the primary care model, huge believers of it, but also we need to acknowledge that there's a big gap and a lot of people are not getting that care. And so we really want to be advocates for expanding the definition of what that looks like. And instead of saying a primary care doctor, let's say a primary care team, right? There can be a lot of people in this team who are thinking about the patients. It doesn't even need to be a clinical person, right? If I have a good care navigator in a clinic who knows about you and is asking about you because you're wheezing and you're having a COPD exacerbation and cares enough to go make sure that we get that filled so you don't end up in the ER, that's what will make an impact and I think really change the healthcare system for us. And so I hope that we'll continue to see that shift. And I think it's, one of the things that is most exciting probably to us at Upperline and our podiatrists is trying to sort of broaden that horizon and say that to folks at health plans or at CMS or elsewhere, who have gotten a really good reception, right? Because they know the supply-demand imbalance. They know they can't, get a patient in to see a PCP in a lot of places. And so it's, we've got to think more creatively about that. And I think that will continue just out of necessity over the next 10 years.
That's so true. Mike King was telling me, patients love going to see their podiatrist. They love making the visits. They love the relationships, and it just makes sense that that relationship and the willingness of the patient to come to those events or those visits with the specialists makes sense to kind of get your arms around. Yeah,
and especially, podiatrists in particular, because we have a lot of data. One of the really neat things that we can say, so I think it's, so if you look at polychronic Medicare patients, roughly 30% won't see a PCP of Medicare members won't see a PCP in a given year. You've got a big percentage that will see roughly 25%, we'll see, I think, 4 or more unique sort of primary care attacks. So people will shop, they go to urgent care, they go to a lot of different places. That's not true with podiatry though. So roughly 86% of patients that see a podiatrist see the same one in a given year. So they don't shop, right? Like they build a relationship, it's really trusting, and like that's gold in these care models, right? Like it all starts with engagement and consistency. And a lot of these other models are really struggling with that, right? Like, they got 50% of their patients churning and going elsewhere. And we don't have that. We've got that as a specialty, sort of a unique place where it's really sticky.
David, that's kind of visionary, like back in 2016 or 15 or 17, when you were getting kind of formulating this plan and you saw the data. Can you walk us through that? I mean, when you're the founder of a entity like Upperline Health, I imagine it goes through different iterations, but what was your vision initially? I mean, how did you do that?
Yeah, it's a great question. So actually our mission has always been the same, which is to transform specialty care towards value-based. Did not exactly know how we would get there. So I think we had a bunch of different iterations. You're exactly right. Initially, we thought we might be more narrowly focused on wound care actually, and work with health plans and have an algorithm that flags high-risk patients and creates different payment structures that are better outcomes at lower cost, right? So you can think bundled payments, things that are happening a lot in the MSK space. And we had a bunch of different iterations and conversations with health plans around that. Ultimately, it's still something that we might end up doing, but I think we learned with wound care patients in particular, it's really hard to identify them via an algorithm because if you think most of what we would use or a health plan would use is claims data, right? Which has roughly a 2-month lag on it. And so if I'm trying to get a patient out of, say, a hospital-based wound center that has an HOPD facility fee and maybe hyperbaric oxygen, things that could be overutilized that are opportunities to lower the spend. By the time they hit a algorithm, they're two months into their treatment at the HOPD wound center. And there's not really a good way to do that unless you're to go to a health plan and say, hey, we want you to utilize it to 100% of these patients, which in 2025 would be unpalatable for an plan to do. And they weren't interested in doing that either, nor is that necessarily the right thing to do, right? To say, hey, every patient needs to get, a review. I mean, there's just too much wound care to do that. And so we ultimately said, look, everyone wants help with these patients. Health plans want help with these patients, but we got to find a different way to engage them. And so we said, look, let's just go upstream. Let's go even earlier before they have, the wounds. Let's just go to the population and take risk and do different payment models around them. And so, we ended up actually starting narrower and then broadened it because of necessity to really target patients. And then, ACO REACH is our primary value-based care arrangement right now. We've got other ones as well, but ACO REACH is the primary one. And we stood that up in 2022. We applied 2023. We went live. we had other programs that we could have gone into as well. And so there was also, a little bit of iteration around which program do you go into as you seek to do value-based care, or you seek to take risk.
At the risk of dominating Joe, I have one more quick question. So ACO REACH, can you help our listeners? Can you define ACO REACH as opposed to Medicare Advantage plans? Just kind of give us the framework of providers and how our audience or listenership can navigate that or understand it. Maybe that's a better word.
Yeah, great question. It is massively complicated, I would say, as Gene is well aware. And this is even doing these programs, you realize like it's so hard for even well-intentioned groups to grasp these things. I think our healthcare system is so complicated. These programs are so complicated. And you got the alphabet soup of CMS programs out there. And so even people who live in this will mix these things up. Like truly, like it is massively complicated. So MA been around for a long time. I think the simple way to think of MA is you've got Humana or United or Aetna who basically get paid a set amount by CMS to manage those patients. And if they manage them for less, they get money. If patient costs more than they get from CMS, they lose money. That is, their revenue is based on how sick they are. HCC is, as Dr. Pascarella was talking about, Gene was talking about, which is basically a numerical value that is calculated from your number of ICD-10 codes. And so, if you're an oncology patient that has COPD, CHF, and a history of wounds, you are projected to cost, I'm making this number up, $40,000 a year, right? So CMS will pay you more if you're that patient versus me, who doesn't have all those conditions. And so MA structured that way. ACO REACH is actually in some ways very, very similar. So they will pay you based on how sick the patients are, the same methodology actually. The difference is rather than it being an insurance company, it's provider groups that are effectively operating like those insurance companies, those Medicare Advantage plans. And so we're doing all the underwriting, the actuarial work of predicting, death, hospitalization rates. Is it going to be a bad flu season? All the things that you would think a health plan would do. These practices in ACO REACH are doing. And the technology that sort of underpins all of that is, has to be in place as well, which is why I say it's complicated and expensive to actually do these types of arrangements. The big difference with ACO REACH than MA is Medicare programs are really strict about not limiting patients. So you can't narrow a network. You can't tell a patient if you're in ACO REACH or MSSP or some of these other Medicare programs, if they have red, white, and blue card, you cannot, go tell them what to do like you can in an MA plan. You can't utilize management things. You can't do a lot of those services. We can offer a lot of the other benefits. And so there's different types of beneficiary enhancements. I think we're probably the first ACO that's trying to figure out a dental benefit for our patients. And so there's other things that we're trying to offer, that it's really an alternative to MA within the Medicare fee-for-service structure, which is, in one way to think about it, it's the most open network PPO that exists probably, right, is Medicare fee-for-service. And so ACO REACH is the most advanced track of risk. So folks like us have 100% financial risk. So we are the exact same as an MA plan in that sense. There are plenty of other programs. MSSP is the biggest Medicare Shared Savings Program. It's been around for the longest. There are multiple tracks in that. And so again, I know this stuff gets very, very complicated, but the tracks correlate to the type of risk. And so that's actually the biggest ACO is MSSP. It's been around for the longest time. The most advanced track of those is still not full risk actually. And so they introduced ACO REACH as kind of the granddaddy, grandmother and them all to kind of have a progression. A lot of people will play in different programs as well. So.
Wow, thank you. That's a lot to dissect for
Yep.
sure. So, Gene, how do you get your providers, how does a provider get their arms around all this? I mean, you help them, I'm assuming, right, with at Upperline.
Thank God it's not that complicated for us.
I love it. Your thoughts?
You know, it's a real paradigm shift, Jeff, as a provider. We're used to going in as a podiatrist, problem focused, right? You have heel pain, you have an ingrown nail, you got whatever. Well, now we go beyond that. You know, we're presented with the diagnosis codes that this patient brings with them from their other providers. We have software that shows us that. We can ask them about these different types of problems they're having. And the real important part is we can act upon it. So if I have a patient that's diabetic that hasn't had his blood sugar checked in 3 months and he's diaphoretic in my office, we have a nurse practitioner right there with us. Now, not all offices have a nurse practitioner right in there, so like we do here, but they have access to one just about immediately. So we can intervene and keep these patients healthy. So we're not looking at just the foot. We're really able to treat this patient more as a whole person and keep them healthy. And the data, and I'm sure David would probably touch upon this, the data has proven that this is working for us. So it's, like I said, it's a real paradigm shift for a provider, but a very gratifying one.
Joe would be welcoming, right? To have a team helping us with our patients. And, you know, how many times have you called the primary care doc and the primary care says, you know, I haven't seen that patient in 3 years. And the next thing you know, their hemoglobin A1C is like 18 or something, you know. Your thoughts, Joe.
Yeah, you know, again, having watched some of this develop over time, and to give you a little background, David, I had worked in Kaiser Permanente, which I think started some of the value-based care stuff when I was still there. I think they were calling it value-based care, but again, as a clinician, we're just like, what do you want me to do? What do I need to do? But in terms of how we start looking at patients, what I love in terms of the intent of it is this idea of a team-based approach. Your data is great, right? It's so useful to back stuff, like things that we think that we know. 86% of people see their podiatrist and stick with their podiatrist. So it does make sense that when I see my patient that I follow up on their A1, say, hey, have you done that? Have you gone to see your doctor? Are you taking care of your other list of things? Even though I'm not going to manage it directly, you know, your COPD or your CHF, it does impact what I'm doing as your podiatrist for you. So let's make sure as a team, we can help Mrs. Smith today. And I love that because it really helps highlight, again, the full potential of what we are doing and what our goal as podiatrists is to help humans with a specific focus on the foot and ankle. What I'm a little curious on is, and you've touched on this, I'm not sure why it has to be so complicated. And I'm sure we're not going to be able to unpack that and answer that in, 20 minutes today. But if you could find some areas to simplify or make things more efficient, just in a perfect situation, what to you are kind of the low-hanging fruit? Because it feels like it's gotten so complicated that like we all have to stay in our lane, because it's too complicated to know. And that it feels kind of untransparent, non-transparent, opaque, right? What are your thoughts on that?
Yeah, no, it's a great question. In some ways, if you think about an insurance company, they've got only a handful of levers to manage their costs, right? They can create a network and say no to things, right? And utilize management things, right? Like they can do care teams and other things like that. But largely, like a lot of it is that. And so that one of the ways they can also do it is funnel it through a PCP, right? Create an HMO type of network. And funnel everything through a PCP, which then actually has the which I think it's an unintended consequence of making it really hard for us as specialists to actually even provide comprehensive care, right? Like we have tons of stories of, and you guys might have your own personal stories of, I've got a train wreck wound care patient and, I try to send them to my vascular referral, but it gets rejected because it didn't go back to the PCP who has to, and then we just throw our hands up. Right, because we're busy, and or you might even get your hands slapped, right? Sometimes, and so I think we've got a system with insurance that is unintentionally actually creating some of these barriers that I don't think, again, they're meaning to, but that are actually creating these behaviors of like intense specialization, right? Of like, do not go outside of your lane, and if you go outside of your lane, we're going to slap you, right?
Yeah.
And I think what we're trying to say is no, let's take a different approach. And rather than doing that, and you know, having all these checks, right, and these checkpoints, instead, if you imagine a world where this is not true for all specialists, right? If you're a general surgeon, this isn't true, but if you have a consistent relationship with the patient, if each of those, and we're saying podiatry for here, but you can imagine this to be true for all sorts of different interactions. If each of those interactions just provided 10% more care, right, or 5% more care, and you multiply that times hundreds of thousands of millions of providers and, you know, hundreds of millions of interactions, like that's how you make our healthcare system more efficient, right? And so I think in some ways, if I were to simplify it, I would say breaking down a lot of those impediments to other people actually thinking holistically about the patients, because I think it's not even just the training, it's actually the system has said, hey, don't do that, and if you do, we're going to slap your hand. And so I think, you know, luckily ACO REACH and some of these CMS programs and what we're doing with MA plans is going to allow us to do that differently for our patients and our providers. Now, you know, hopefully that will grow from there. But I think, you know, that's one of the things. The other, I would say, and maybe this is a controversial thing to say, but you know, as we think about AI and technology, particularly in the health plan side, I know there's a lot of fears that you're going to have a robot denying care, right? And you know, that's out in the ether somewhere, and making life death decisions. When the reality is, I think as a provider group, we would love if everything was published and transparent, right? Where a robot could, where it's just a logic statement, right? It's these things are checkbox and it gets approved or not. And we all know that's not how it works today, right? Because it's so complicated, and it goes to a nurse who, you know, depending on what she ate, is reviewing the things and giving you approval or not. And so, you know, I do think if we can get over some of the fears of you know, the Terminator denying care for us, that it can also ease a lot of those things, so that we're not having to do so much work to actually think holistically, you know, about the patients. And the last thing I would say, as you guys were, and Gene was talking about this with, you know, sort of the PCP engagement, or Jeff, it might have been you actually was saying, you know, sometimes you're called a PCP, it's like they hadn't seen them in 3 years. And I'd say that's one of the things that's been most surprising to me, and Gene, I don't know if you have, if you've noticed this as well, as we rolled this out, a lot of our doctors were like, no, the PCP's doing that, right? They would say that because they sincerely believed it, because the patient probably told them, hey, this is my PCP. But we've got all the data. We know if they've seen their PCP, right? And like, we will cheer it up and say, they hadn't seen their PCP. We don't even know who that person is. They hadn't been to a PCP in 4 years. And like, we don't know it because we're so siloed, right? And so anyway, so I think if we can start breaking some of those things down, it will make everyone's life more fun, and I think encourage more specialists to say, hey, like, you're here, what's wrong? Tell me what's going on in your life. Because a lot of our patients also don't know the difference, right? Like they're going to tell, you know, ask Dr. Pascarella about the COVID vaccine. I bet you got questions, right?
Yeah.
So.
Absolutely. I have a question for you. I started thinking about the ACO REACH program, and that's not involved, as you said, with United or Aetna or Humana. Is there lobbying at the federal level? I mean, they must not be super psyched about a different ACO REACH program as opposed to their Medicare Advantage program.
It's really interesting. So yes, there has been some lobbying. Initially, actually, a bunch of them started their own ACO REACH plans, even though they're insurance companies, funny enough. Most of them have gotten out of it. There's a few that are still in it, but most of them have gotten out of it, but they initially did start. Yeah, there's very strange language in there in terms of how we can market and what we can say to patients that I think seems to me to be written sort of as a a way to appease some of the MA fears, I guess, that we're going to be stealing patients from them. The reality is, like, it's a different patient population, and you know, I don't think it's you know, should be seen as much of a risk. At some point, MA growth slows. I mean, this year I think it was the slowest it's been in multiple decades, like 3.8% or something like that. You know, at some point that slows, and a lot of the people who wanted Medicare Advantage are in it, right? And there's a lot of people who aren't Medicare Advantage, and they're going to want innovative programs and things as well. So I hope that tension and those fears have died down, but initially they were absolutely there, and you can see it in some of the language, like we can't put CMS on a letterhead to confirm to patients that they're a part of the program, which makes them think it's a scam, right? And those types of things, because I think that sensitivity with the insurance companies.
Joe, I apologize. I was stepping on your toes there. Sorry.
Yeah.
No, I was just going to ask Gene kind of his experience with making that transition, and kind of the changes that you've seen over time in terms of how it helps you coordinate care, and kind of what your experience has been.
Yeah, like I said, Joe, it is a paradigm shift for a provider, and it
Yeah.
does take a little bit of time, but not a lot of time. It's very gratifying.
Yeah.
We usually start each of our meetings with a success story on a patient that would come in that had a problem that would have gone unrecognized that we caught. And just a personal story for me that's really sealed the deal for me on the ACO and treating patients in this manner. A husband and wife couple that come to see me, routine care type people, right? They're coming in every 9 weeks consistently for year after year after year. They're married for 50 plus years. I walk into the room on whatever day of the week it was, and he said, "I got to thank you." I said, "Thank me for what?" And he said, "This weekend, my wife was extremely ill. So even if they have a PCP, that doesn't mean the PCP picks up the phone, right? So they tried to reach the PCP. They could not. They called the nurse practitioner that works with our office, who went to their home and helped them."
Yeah.
So when I heard that, I knew we were on the right track. And
Yeah.
the people that I work with in Georgia, you know, I try to get them to understand that. And once
Yeah.
the provider understands that, like you would or Jeff would, I mean, you get it. That's why we're there. We want to help people, you know, not only with their foot, we want them better no matter what.
Right.
Once they get that, they're willing to do whatever they need to do to conceptualize this thing, and, you know, how do they do the coding and the things that go along with it.
Yeah.
So
Yeah.
it becomes easy at that point.
Yeah, Gina, I would love your thought. I mean, my experience, my sort of number I would say is like 95-ish% of the docs, when it clicks, they love it. There's 5% who I don't know that they'll ever, you know, gonna totally embrace it, and that's probably gonna happen with any section of a population.
Yep. I think 95 is a great percentage.
Yeah. I mean, Jane, I would love it. What you think within the docs that you know, and like some of them get it. As Gene said, like some of them, it's like you tell them once and they hear a story and they're like done, and they're like evangelizing out there on the corner, and it's great. Then there's others that you know, they think, is this old MA HMO? Is this like that? There's this again, this alphabet soup, and they're like, wow, what is this? Is it gonna pass? Yeah, that's right. But Gina, I don't know what percentage would you say that's sort of too generous, or
No, I would say it's a very small percentage.
Yeah.
And those that do feel that way, they simply do not understand it. And that's the whole reason why they're not embracing it. Or they're just too busy. They think, I can't treat your congestive heart failure. I'm like, you're not.
Yeah.
You're going to send them to a person that can when they need help.
Exactly.
Okay. So, you know, once they get past that, and I'll tell you, the younger generation, they get it like that. Okay.
Yeah.
It's us guys have been out there for a little while doing this, that are more set in our ways, that have a little bit more of a challenge with it.
Yeah.
But eventually they get it.
And the training of the younger guys too, right? I mean, some of them come out of school, like they're fantastic at identifying this stuff.
Exactly. Yes.
And I'd love to you had mentioned a little bit about the idea of leveraging technology. You kind of mentioned AI, which again could be like a whole nother 2-hour discussion about AI. Can you talk a little bit about other areas where you guys have been able to leverage technology, maybe telehealth, or you insert your technology where you feel it would shine the most, and how that's also helped you improve access or continue that care for your patients?
Yeah, I can go, and then Gene, feel free to add in the others. I think one of the coolest things about this CMS program is when you're the insurance company, which effectively we are, you just care about good quality for the patients, right? And so you will do anything if there's a patient who we're worried is about to have an avoidable hospitalization in the story that Gene just gave. Like that means you'll send an NP out to the home or social worker or somebody like that. Or it means, we've got someone on call who's got full access to their medical records, and it's an NP with an MD overseeing them. And they can see the whole sort of life cycle of that patient, because as you're, sort of moving to the insurance company, like we've obviously got our EMR data, but we've also got all the claims data, and you've got pharmacy data. And so you're really able to see comprehensively, this is a patient who has all sorts of different risk, and we'll predict, sepsis risk, we'll predict fall risk, we'll predict end of life risk, we'll, starting to predict, hey, these are social determinants of health, which probably lead you to believe certain things about this patient, right? We should be aware of it. And so we can flag all of those things now, and the care teams and the clinics see it every morning. They see the patients, that are coming in. They know their risk stratification. They know who's just been hospitalized. We are getting ADT feeds from the hospitals in real time. So we know who just got hospitalized. We've got a whole care team who's working with the discharge planners to avoid readmissions, to try to get them, as soon as they get discharged. We've got a whole protocol to follow, and that's sort of automated within the system. So there's some really cool things that are happening there. I think it is mostly the one thing I always say about technology and healthcare is healthcare at its core is a service industry, and it's a person-to-person relationship. And I don't think AI technology, Bluetooth enabled glucometer is not going to fix that, right? It's going to blink bright red and call a call center, but unless you have a provider that's trusted or a dietitian or somebody who's trusted to sit down with that patient, saying their A1C's, out of whack, is not going to do anything when, they call the call center in Pulaski, Tennessee, right? Like, what are we going to do with it, right? And so, you've got to have that trusted relationship, which goes back to that 90% that don't move, they stay. That is the most valuable thing in these arrangements. And so predicting and flagging these and connecting all the dots, is great. And in some ways, fantastic magic that happens as a result of all these investments that have been going on in healthcare over the last decade, right? It's you're actually seeing some of these things come to fruition, but that without a provider means nothing, right? And there are companies that will use all that data and predict stuff. And it's cool, so what? Right? The patient's not going to answer a random call center call, right? That says, hey, you're at risk of this. You don't know me, and you don't have a provider, that I have a connection to. He didn't ask me to call you. That's what a lot of care management programs have done historically, right? They use all that data and they predict, and they just outreach to patients. And they have, 10% engagement or something really, really tough because there's no relationship. This is it's very personal, right? And it's always fundamentally built on trust. And so, anyways, I think there's a lot of cool things that were happening. I think ours only works because we've got providers that are so trusted. So, Gene, I don't know if you have other ones.
I do. On the provider end, the user end.
Yeah.
Not ask me how these work. I'll just tell you what they do. I have no idea. So we have a software platform that bolts onto our Athena that provides us with all the diagnosis codes that this patient has ever had attributed to them. Okay. It tells us who made that diagnosis, when that diagnosis was made, all the history of that, so that it's validated. So we have that piece, which is really important to us, so we can talk to the patient. Secondly, we have another software that's, I would say it does intelligent prompting, and it's for wounds. So if somebody comes in with a wound, you're measuring this wound, you put in your information, you're documenting it, it's going to prompt you on different types of things that you should be thinking about. And if that wound is, and it remembers this. So if they're coming back the fourth time and size of that wound hasn't changed, it's telling you need to refer this to somebody. So,
Yeah.
so we have those tools available to us on the user end. Super helpful.
Oh, that's awesome. Yeah.
Yep.
It's incredible. Before we talk about, the future and podiatrists and, employment with Upperline down the road, I had one more question for you, David. How did your background, you have a undergrad in history, how did that shape your ability to think about healthcare, or did it even affect
Great
your
question.
ability to frame it?
Yeah, I have a very nonlinear background, which is what you're referencing. I'm a humanities liberal arts product. So it was history of late antiquity, which is fall of of the Roman Empire to the Dark Ages, essentially. And then I went into politics and did the equivalent of what Doge is doing right now for the state of Tennessee during the recession. And so non-linear in so many ways. I think healthcare, and actually I was encouraged by a lot of folks. I mean, Nashville's got a lot of healthcare entrepreneurial sort of spirit and things coming out of here. And I was encouraged by a handful of folks when I was actually leaving government to go to healthcare, even though my background was not healthcare, because we needed folks with different perspectives. Healthcare, particularly in Nashville at the time, was I would say that the number one thing that they valued was experience. And the joke that I used to always say is, to get a job as an incoming open first time analyst job, every job required 5 years of experience. It was like, I don't know where any of these incoming people are getting any of the experience. It was the one thing they valued so much, which I think creates this echo chamber of repeating things over and over and over again, right? And so if anything, humanities, liberal arts, it's just about looking at problems in different ways and thinking creatively. I think it has certainly contributed to how I just think of problems. Gene knows this because he's been with us since the very, very beginning. I will come up with 10 bad ideas a week on average, and sometimes more. And so, I think, and our whole team will do that, right? Like we try to always have, different ideas and different ways of looking at things, and very few of them stick. But always trying to do that, I think, is, what an innovative healthcare company hopefully will always do, even as we get bigger. I hope we don't lose that. And so we've actually recruited folks, from a lot of different backgrounds. Our chief people officer, we were intentional about not getting somebody with healthcare experience, because I think most healthcare cultures are not great. And I think there's other companies and sectors that have better cultures. And so, we've been sort of intentional at various junctures to say, hey, I don't want a healthcare perspective on this, right? I want something that's totally new, because, healthcare's not good at this. So, yeah.
That's interesting you say that. When I was younger, I used to quote Jimmy Buffett. Now I'm quoting Warren Buffett. He said that, I just read this recently, a lot of business talent is innate. And that's why I'm asking, because with that background and that perspective, and then a bend towards efficiency and things, I don't know, I just think it's great for listeners to hear stories of people. So thank you so much.
Yeah, no, I'm always a fan of Jimmy Buffett quotes. I think they're easier to understand than Warren Buffett.
David, can I throw this in there? Can I throw this in?
Sure.
And I don't know, you can tell us, David. He also studied classical guitar. And I think people in music and music theory, they think very analytical. Have to. So I have a feeling that plays a part in his decision making and what brought him to this point as well.
Yeah, that that is probably very true. I think classical musicians generally are very structured and analytical. And as Gene's alluding to, we like numbers. We talk a lot about numbers, sometimes probably to a fault, but no, I think that also helps in, you know, in healthcare, which is, there's just so much noise, right? Like it's so hard to figure out. And like one of the things, Joe, as you were, you know, talking about some of the things that what makes it complicated. You know, if you think about, I'll put an example of one. You know, there's this sort of now publicly litigated debate over, is Medicare Advantage saving us money or not, right? And it is way more complex than a single Wall Street Journal article could, you know, hope to try to capture, right? Because you have to say, well, you know, who is the baseline? And the baseline is, you know, infinitely complex, right? Like, you know, you're going to match it based on patients, you're going to match it based on demographics and markets and where they are in their trajectory and adverse or, you know, patient selection, all those types of things. And when you get to those sizes, like there's not sample sizes that you can really, you know, compare it against. And so that's one of the things that makes all these programs actually so complicated is, it is, you know, no one wants to set it up where folks are either making too much money, right, by doing it as sort of insurance companies, or where they can't and they're not going to, you know, participate. And so that all ultimately boils down to what do you set a savings target at? And the savings target is always going to be tied to like, what do you think the expense is, right? And so, you know, if we were to say, you know, some group of surgical doctors said, hey, podiatrists have more expensive results for these surgical procedures without risk stratifying the patients and saying, hey, you know, we have 15% more that are, you know, uncovered care and all those types of things, then like we all know it's meaningless, right?
Right.
Like, we know that.
Yeah.
But for a headline, people
That's
don't
right.
necessarily do that, right? And so I think you got a lot of that happening right now, unfortunately, and you know, people with, it's become very, very political, which I wish it wouldn't, right? I think everyone actually wants, you know, the same thing, which is to get better outcomes at a lower spend within the healthcare system. And we should acknowledge that this is nuanced and complicated, and we can disagree on methodology, but let's not be intellectually lazy and dishonest about these things.
Right. And just to reemphasize, I love what you'd said something there. I'm not going to say it exactly the same, but if we can align those goals of high quality, low cost, and at the end of the day, improve patient outcomes, everyone wants that.
Right.
So how do we figure out where the noise is and get rid of the noise? And how do we help our patients understand why we're doing whatever decisions we're making? And you're right, like all I'm so tired of all the clickbait, right? Like there's a title and it doesn't even matter anymore. People don't even read the article. So even if their statistics are terrible or what they're trying to highlight aren't valid, it doesn't even matter because the headline was catchy enough. It gets sent around within seconds and the damage is done. So that just makes everyone's job a little more hard.
Yeah. And I think specific to our industry, I think that's one of the things that we've got a ton of data. We have a very big data, so we're trying to help with that, hopefully this year with some partnerships, and be able to leverage that and produce, you know, some more research and some more paper. That's actually one of the things that Gene has helped lead with us, you know, to again, I try to sort of make our way through the noise, and start to say, hey, you know, what's the real signal here? There's a lot of really well-intentioned providers, you know, doing their best. And so like, what can we learn about this?
Yeah.
Love that. We're near an end of time, but I just wanted to leave a minute or two to talk about the future of Upperline with podiatry. I know a lot of students are asking me, you know, graduates of 2-3 years ago, hey, what are the opportunities you see out there for employment? Your thoughts on that, David, Angie?
Yeah, Gene would know more of the numbers than I would. I think we're, you know, we're probably going to hire, what, Gene, 30 or 40 providers this year. that number probably only continues to grow. So maybe for another day, we'll talk about the student and the graduation and how we get more folks to do this, because we're very much needing and looking for talent always, and that's not going to die for us. That's only going to continue to grow for us. And we've, I think, recently, within the last, call it 6 months, gone to, I think, 9 or 10 new states. And so we're basically east of the Mississippi, with Texas and California and Minnesota being, I think, or west of the Mississippi, if my geography is right, states, and probably all of those, whether right now or within the next 12 months, we'll be looking for talent. But Gene is way closer to I am than on the recruitment and the needs, and lives that daily, I think.
Jeff, I can tell you, just leading up to this call, I was on another call where we're putting offer letters out to 5 podiatrists just for Atlanta, just for the Atlanta area. And we just got off that call prior to this one. So there's plenty of
maybe we could do another episode, get the Dr. DeHere on and a couple other docs that are involved in training and employing, associates and things. That'd be great. Joe, any final thoughts on your end?
No, I'm so excited about the work that you guys are doing, and it's nice to have large data sets to support the things that we're talking about, to say that we are streamlining care, we're improving efficiency and patient and provider satisfaction. Like, all of that matters. And so I'm excited to see what continues to develop. But I think the mission and the vision here is really, again, that's an excellent goal.
David and Gene, thank you so much for joining us on Dean's Chat today. It's just been a joy discussing healthcare and podiatry with you.
Thanks so much, guys.
Thank you, everybody.
Well, to all of our listeners out there, if you're on Apple or Spotify, please give us a 5-star rating. Joe and I are always asking for comments, so please leave a comment. And if you're watching on YouTube, by all means, become a subscriber, and we will continue to bring you leaders in the profession and interesting guests like David Thorpe, Gene Pascarella. Again, thanks a lot. And by the way, we are going to be sending the Dean's Chat Cup. You guys are working around the clock. You need some caffeine. We're going to help with that.
I can use
very
one.
well sized.
Absolutely. All right. Cheers, everybody. Have a wonderful week. We'll see you next week. Bye-bye.
Thank you so much.